For the last part of this week's series of lectures, we're going to dive into concussions and brain-related traumas. So the word concussion is from the Latin verb congutere, which means to dash together or to shake. In relation to medicine, a concussion is a traumatic brain injury that is trauma-induced and may or may not involve the loss of consciousness. In relation to sports medicine, a sports-related concussion is a concussion that represents immediate and transient symptoms of traumatic brain injury in sport groups. Concussions may be caused by either direct or indirect trauma. They may be caused by a direct blow to the head, face, neck, or they may be caused by an indirect blow to the body that causes impulsive forces to be transmitted to the head. Direct blows occur when the athlete is struck in the head by some object, i.e. a baseball bat, a lacrosse stick, or even another player. A direct blow may also occur when the athlete's moving head strikes some fixed object, like the floor or the ground, or a goalpost. A blow to the head can produce an injury to the brain either at the point of contact, which is known as a coup injury, or on the opposite side, which is referred to as a counter-coup injury. An example of a counter-coup injury would be the whiplash injury. Acceleration, deceleration, and particularly rotational forces produce shaking of the brain within the skull. A concussion can happen really at any time, in any sport. All athletes are at some risk for sustaining a blow to the head, neck, or face in one way or another. But that being said, the athletes that are at the highest risk for a concussion are those that take part in contact or combat sports. So sports like football, rugby, or lacrosse. To a little lesser degree, athletes in basketball and soccer are also at a higher risk. And then even in sports like track, cross country, or diving, if an athlete falls and hits their head on the ground, or if a diver hits their head on the diving board, they are also still at risk for developing a concussion. Age also plays a large role in a risk for sustaining a concussion. Younger athletes are still growing, and their brains are at a higher risk for being injured with minor impact to the head, neck, or face, especially if they are not demonstrating proper technique with movements like tackling opponents. Lastly, those that have a history of concussion are at a higher risk for sustaining another concussion. Much like those who have had previous heat illnesses, their bodies become more susceptible to a repetitive injury and remain at a higher risk for developing concussion for the rest of their lives. With a concussive force, some brain cells are destroyed as a result, and other cells are at a higher risk for secondary trauma due to changes in the cerebral blood flow. Also changes in the increased intracranial pressure and changes due to apnea. Apnea is just a breathing disorder linked to traumatic brain injury that may obstruct the airway and impair brain function. After a traumatic brain injury, a paradoxical pattern occurs where there is an increased demand for glucose to be delivered to the brain to fuel cell metabolism and begin the healing process. However, the blood flow is inhibited after a person sustains a concussion, and this reduces the amount of nutrients that can reach the damaged cells in the brain, which is going to exacerbate the injury. This is why when a person sustains a concussion, they may feel only slightly unwell immediately after impact, but they also then begin to feel much worse as time passes. So what are the neurochemical and structural changes after a concussion? For neurochemical changes, we have first ionic imbalance. So the trauma causes neuronal stretching and membrane disruption, and this leads to an efflux of potassium and an influx of calcium ions. This ionic flux disrupts normal electrical signaling and can trigger spreading depression, a wave of suppressed brain activity. There's also an energy crisis, so to restore ionic balance, neurons increase activity of ion pumps, which require large amounts of ATP. And then this leads to hyperglycolysis, so increased glucose consumption. But the cerebral blood flow is often reduced, which creates a mismatch between energy. So it basically creates a supply and demand mismatch. Lastly, with neurochemical changes, we have neurotransmitter disruption. So there is often an excessive release of excitatory neurotransmitters. So neurotransmitters like glutamate, um, and that excessive release can lead to excitotoxicity, which is going to damage neurons due to overstimulation. Some of the structural changes that occur, first is there is white matter damage, so the white matter of the brain. Concussions can cause a diffuse axonal injury where the axons are stretched or torn, and that's going to disrupt the communication between the brain and various regions of the body. There's microstructural changes, so we see these through different imaging systems, imaging devices, and they show alterations in white matter tracts and reduced integrity in areas like the corpus callosum and the frontal lobe. There is neuroinflammation that occurs. The injury is going to trigger an inflammatory response, just like every other injury in the body. There's some sort of inflammatory response. So this inflammatory response, this neuroinflammation, activates microganglia and astrocytes, which can contribute to chronic neurodegeneration, especially if unresolved. Then there's also blood-brain barrier disruption, which the blood-brain barrier is the protective barrier around the brain, and it may become more permeable, which allows harmful substances to enter the brain and continue to exacerbate the injury. So although in healthcare, traumatic brain injury and concussions are often used interchangeably, there is a difference between them. A traumatic brain injury is any injury to the brain that is caused by some sort of external force, and then a concussion is just a subcategory of a traumatic brain injury. So a concussion is a type of TBI. Traumatic brain injury is classified in one of two categories. So we have closed brain injury, which happens when there's no penetrating injury to the brain, and there's no break in the skull or no fracture in the skull, and the penetrating brain injury. So when where we have a penetrating brain injury, there's a penetrating or an open head injury that happens, and there is a break in the skull or a fracture in the skull involved. Other subcategories of traumatic brain injury include diffuse axonal injury, or DAI. This is the shearing and tearing of the brain's long connected fibers, or the axons. And that happens when the brain is injured as it shifts and rotates inside of the skull. And then we also can talk about brain contusions or bruising on the brain, which damages the internal tissue and the blood vessels. And then there's other injuries that are also classified as traumatic brain injuries, including tumors, stroke, brain hemorrhage, and encephalitis. Other signs may be loss of consciousness, fatigue or drowsiness, or disturbances with their sleep patterns, where they are overly tired or they are unable to fall asleep, so they have insomnia. Dizziness or balance issues, so the patient may experience nausea or vomiting along with that dizziness and balance issue as well. They may have slurred speech and a delayed physical response and difficulty concentrating. Other clinical symptoms include confusion or disorientation, feeling just generally unwell, or that they are dazed or in a fog, or that they're just not all there. The patient may experience emotional irregularities where they have extreme mood swings. I've also had patients who demonstrated everything from mild irritability to actual violent rage. I've also had patients who had just overwhelming sadness, and then feelings of anxiety or extreme nervousness have also been some things that I've noticed with some patients who have sustained a concussion. They may have ringing in their ears. They may have blurred or double vision, sensitivity to lights and sounds, and then there's also slowed thinking and responses, and they may also experience amnesia. So amnesia may present as either retrograde amnesia or anterograde amnesia. Retrograde amnesia is the inability to remember events before a specific incident. So the individual with a concussion, they may not remember getting hit, but they'll remember everything after getting hit, but they won't remember anything before. So I've also had an athlete who was not able to recall his own name. I've had an athlete who was not able to tell me where he was from or even who he was. So that would be an example of retrograde amnesia, very severe retrograde amnesia. But oftentimes I see a lot of retrograde amnesia where the patient sustains the concussion, and then they just don't remember getting hit, and they don't remember maybe that the play that they got hit on. They maybe remember some of the game leading up to the event, but they may not remember all of it. Anterograde amnesia is the inability to form new memories after a specific event. So they may remember everything up to the point where they got hit or they sustained their concussion injury, but they may not remember how they got off the field after they got hit, or how they got to the hospital, or how they got home from the hospital. That would be an example of an anterograde amnesia. They're unable to start forming new injury or new memories. All of these signs and symptoms may appear, or maybe the patient only experiences one of these things. Okay, most likely the headache after impact will occur regardless of the number or severity of signs or symptoms that the patient presents with. A concussion is a concussion. So in the past, we used to grade concussions like a mild concussion all the way up to severe concussion, but we've moved on from that in healthcare. Thankfully, we moved away from that to better protect athletes and their brain health. So just remember, a concussion is a concussion, and all must be treated as severe injuries. I'm sure I've mentioned this in a previous lecture, but there is a difference between assessment and diagnosis. Assessment is essentially getting your best guess based on physical and or cognitive testing to determine what an injury might be or most likely is. And then a diagnosis is using those same physical and cognitive testing procedures in combination with more advanced imaging to help determine what an injury for sure is. Okay, so an assessment is what it most likely is, and a diagnosis is absolutely what it is. Because coaches and athletic trainers do not have access to advanced imaging on the sidelines or wherever they may be when an athlete is injured, they can only assess for concussions. Physicians can use advanced imaging devices, namely the CT or the computed tomography scan for concussions to determine the level of damage that has occurred to the brain. If the assessment, though, is done comprehensively by the coach or the athletic trainer, they're usually correct, and the patient is usually quickly diagnosed by a physician. Baseline testing is an assessment that must be done for athletes, especially those participating in contact sports, before their season begins. Okay, not after, not during, before their season begins. Baseline testing should be done, and the baseline test measures the healthy and uninjured athletes' memory, attention span, balance and proprioception abilities, and their reaction times. If any of you are in sports or continue to be active in college athletics, you have almost certainly taken part in a baseline test for concussions. You probably took part in one of the most common baseline testing tools, which is the impact test, which is just a battery of different tests to help create a baseline for each individual athlete. Through baseline testing, we're able to have personalized comparison points for each individual athlete that provides a benchmark for each person's cognitive and physical abilities, and that allows for more accurate post-injury comparisons. It allows for improved concussion diagnosis, where the physician can compare current test results to that of their baseline data to detect even the most subtle changes in the brain function that might otherwise go unnoticed. There's greater objective data, which creates safer decision making. So baseline assessments help eliminate any guesswork and reduce reliance on self-reported symptoms, which an athlete may underreport to be able to return to play sooner. So it helps get safer decision making and keep those athletes safer. It also helps, these baseline testings help guide return to play protocols by ensuring that athletes only return to sports when their brain function has fully returned to their baseline. And that's going to reduce the risk of second impact syndrome or even a prolonged recovery. And lastly, a baseline assessment helps just raise awareness and encourages athletes, coaches, and parents to take concussions seriously. So it just helps promote a culture of safety around concussion injury and promotes a culture of preventing concussions. There are many different ways of assessing a concussion, but without a doubt, the most comprehensive assessment tool is the Sport Concussion Assessment Tool, 5th edition, better known as the SCAT-5. This is a battery of clinical measurements that identifies red flag symptoms, notes observable signs, and grades a series of symptoms on severity. It notes any loss of consciousness and utilizes the Glasgow Coma Scale. It assesses memory, orientation, and concentration, as well as balance and coordination. And it also includes the standardized assessment of concussion instrument. As concussion research has continued to advance, there have also been extensions of the concussion assessment to include the vestibular ocular motor screening, or VOMS assessment. This looks at smooth motor pursuits. So smooth motor pursuits are how well does the patient track a moving object. Of importance with this test is the presence of an nystagmus, which is where there's a subtle, or in some cases a not so subtle, flickering or a twitching of the eyes as the patient attempts to track a moving object without moving their head. The VOMS assessment also looks at horizontal and vertical saccades, where the patient keeps their head still and moves their eyes quickly between two different points that they must focus on without moving their head. Convergence is the ability of both eyes to track an object as it moves closer to them. So the clinician looks basically to see if the patient can cross their eyes and if their eyes move equally and without nystagmus while doing so. Horizontal and vertical vestibular ocular reflex is where a patient focuses their eyes on an object and then moves their head without their eyes losing focus on that object. And lastly is visual motion sensitivity, which assesses how well the body processes visual information when it is moving. So this is assessed by having the person rotate their head, eyes, and trunk as a single unit while the patient focuses on a stationary target. So basically the patient holds their arm straight out with their thumb up, and they focus on their thumb as they rotate their trunk, neck, and head as a single unit. So attempting to maintain focus on their thumb, the patient's ability to maintain focus and experience minimal increases in symptoms is evaluated in that way. Each of these tests can exacerbate the symptoms of the concussion or of the concussed patient. So they're asked after each test to rate their symptoms following the conclusion of each part of the exam. Immediate care of the athlete is extremely important for the prognosis of the patient. So the first thing you need to establish is if there was any loss of consciousness associated with the injury. If there was, you must also treat it as a cervical spine injury. If the athlete regains consciousness, rule out any cervical fracture before attempting to move them or have them sit up. And then if they remain unconscious, they must be spine boarded and transported by EMS to the emergency department as soon as possible. If you have ruled out any cervical spine injury and any fracture of the face or skull, you may move them to the sideline or better yet, to a more quiet, private assessment area where you can where they can collect themselves and you can perform an assessment without interruption or any immediate distractions. Utilize the SCAT-5 form and a VOMS assessment to identify the full extent of their concussion and associated symptoms. Always, always, always be overly cautious when it comes to concussions, especially in younger athletes. But always be overly cautious when it comes to concussions. Each human only has one brain for their entire life, and any decision you make, it can affect them for the rest of their lives. So always err on the side of caution. After I perform my assessment, if the athlete has even one of the symptoms associated with a concussion, I don't let them return to play unless I've allowed enough time to pass for reevaluation, so that I can reevaluate their level of injury and the presence of any traumatic brain injury. If you make the decision to remove an athlete from play, do not let anyone make you feel bad about your decision or talk you into returning them. It doesn't matter if it's the athlete or a teammate of theirs. It doesn't matter if it's a coach or even their parent. You are the one who is trained to make the decision, and you need to be confident that you are placing the health of the athlete ahead of any singular athletic event. Again, they only have one brain for their entire lives, They can always return to activity after they have been properly cared for and have gone through the appropriate healing process. After an athlete has been removed from play with an assessed concussion, give them and a responsible adult who can care for them information. Okay? Not once have I had someone get a concussion and just take it in stride. There are always questions that people have, and it is important that you answer them. Not only to make sure that continued care can be given to the patient, but also to help relieve the patient's stress or the caregiver stress and to help them cope with their injury. Okay? Inform them that they may feel worse before they get better. Oftentimes, symptoms progress in severity for up to 2 or even 3 days after that initial concussion was sustained. And this is normal and it's somewhat expected, so make sure that the patient is aware. Give that patient an estimated recovery time. I've listed a few here. These are estimates. They're very general, and by no means are they always accurate, but they at least give the individual a guess at when they're going to be able to start feeling better. But especially if the patient is having issues with their memory, ensure that they are going to be in the care of a responsible adult who will be able to care for them for the next 24 to 48 hours. These adults should be made aware that there are several signs and symptoms that signify advancing brain injury and or an underlying lesion in the brain that is resulting in hemorrhage. These include any subsequent loss of consciousness, a seizure, advancing visual disturbances, muscle weakness or decreased muscle functioning, or slurred speech that continues to get worse. This responsible adult and the patient should also be made aware that it is okay to take some over-the-counter NSAIDs for any headache that they may have. But makes them aware that Tylenol and naproxen are okay to take, but because ibuprofen has a thinning effect on the blood, it should not be taken as if there is an ibuprofen shouldn't be taken because if there is an unidentified lesion on that brain, it may progress that bleed and cause intracranial hemorrhage to occur. The patient should be instructed to rest, okay? So we really want to make sure that they limit their screen time. We want to reduce their exposure to bright lights or loud noises, especially if they have sensitivity to light or noise. And to make sure that they set a scheduled time to go to sleep and a time to wake up. That's going to help promote a return to a normal circadian rhythm, which will help to heal the brain. If there are continued sleep disturbances associated with the patient's concussion, they can use melatonin to help aid their sleep, but that should only be done after several days have passed since their initial injury. Although post-concussion syndrome is widely reported, there really is no standardized definition of what it actually is. But what it can be characterized as is prolonged cognitive impairments that may last anywhere from days to weeks after the initial injury. Post-concussion syndrome is typically associated with decreases in attention span and trouble concentrating. There's usually impairments to memory and emotional irregularities. Furthermore, any exertional activity may result in a return of headache. It may increase dizziness or it cause balance loss, and it may also cause feelings of undue fatigue. If left untreated, long-term consequences can result in balance and proprioceptive disruptions, decreases in cognitive performance, and progressively worsening emotional disturbances. They may also withdraw from any and all social interactions and continue to have poor academic or professional performance. Treating the syndrome is similar to managing concussion. The patient should have plenty of cognitive rest, meaning that they should have reduced schoolwork or professional responsibilities, or none at all if they are working on a computer and that really exacerbates their symptoms. And they should not be allowed to participate in any exertional activity. Now, that doesn't mean that they need to isolate themselves in a room and stare at the paint dry with no interaction with the outside world. They can go on walks, light walks for up to 20 minutes to get some exercise, as long as they do not have any symptoms that are worsened by doing so. Second impact syndrome, quite bluntly, is caused by careless medical providers. Physicians, athletic trainers, and even coaches can be careless in the care of concussed patients and allow them to return too early to athletic activity. If a patient is still healing from a concussion and they sustain a second concussion, they may develop second impact syndrome, which is associated with cerebral swelling. And diffuse cerebral swelling has a 50% mortality rate. So before an athlete is returned, and before you return an athlete to play, and you're sitting there questioning if they have completely healed or not, just ask yourself, are you willing to flip a coin on if that individual lives or dies, especially if they sustain a second concussion? Okay. Again, this is very blunt, but we all need to be aware of the weight of our decisions and how they can lead to the death of an individual if we are careless with our choices. Those individuals that have second impact syndrome, they typically will begin with the same signs and symptoms that they had with their first concussion, but very rapidly. So I'm talking about within 20 to 45 minutes, they will begin to go downhill fast. They'll begin to lose consciousness and then completely lose consciousness. Okay. They will become unresponsive to any verbal or painful stimuli, and they will also have no pupil response to light or movement of their eyes. They'll then begin to lose their ability to breathe on their own as that intracranial pressure continues to build, and it's going to disrupt the function of the phrenic nerve and limit their ability to breathe on their own. If we notice any of these signs or any of these in an individual, we need to act immediately to give them any chance of survival. Because again, there is a 50% mortality rate with diffuse cerebral swelling. So we already know, we already have the odds stacked against us in this situation. So get them to an ambulance as quickly as possible and to an emergency department so that they can get the life-saving care that they need. Now, that was a pretty intense, pretty heavy last slide, but I want you to know that most concussions are not life-threatening, and most athletes fully recover and return to their sport and continue to live happy and healthy lives afterwards. But it is important to understand that if we do not treat each and every concussion with respect and caution, the patient can suffer prolonged consequences. So you need to be fully aware of how to identify and assess a concussion, and always err on the side of caution to prevent any further damage to another human being's brain. Not only do you need to be aware, but make sure that you give as much information to the patient about the healing process of the brain and how to appropriately care for themselves during their recovery. Lastly, make sure that you are aware of your return to play guidelines and follow them without exception. They are created to ensure that you have done everything that you can do to not only safely return your patient to the sport that they love, but to make sure that their one and only brain will be healthy to last them for the rest of their lives.